Thank all of you for coming out today. Great crowd. And what my role here is to kind of set the stage with some of the background on key aspects of the Act and a little bit on how they've worked so far, and then talk a little bit about the big picture questions that we have to answer if we're going to try to repeal, replace, or repair the Act. Broadly speaking, the Act has three objectives. One of them, the first one I have up here, gets about 99.99% of the attention, which is why I'm also going to have slides for the other two, as I think they're also important. The thing that gets all the press, of course, is coverage. Primary objective of the Act, to get more people insured. How well has it worked? I'd say moderately well. Maybe a little bit disappointing relative to expectations. I think if we'd asked in 2010 when the Act was passed, what would be the uninsurance rate in 2017, you might have come up with numbers of around, say, 4, 5, 6%. And we're roughly double that, but nonetheless, we're substantially below where we were before the Act was passed. Among American adults, the uninsurance rate the last quarter before the Act's main provisions took place was a little bit above 17%. And it reached a low of 10.9% in the third and fourth quarters of last year. It ticked up slightly to 11.3% according to Gallup in the most recent quarter, which may partially reflect some of the changes that the new administration brought about, such as canceling or delaying some of the advertising in January. Enrollment was actually running a little bit above 2016 pace on the exchanges until that last quarter. So overall, we've got about 12 million enrollees that have their coverage through the private health insurance exchanges, essentially the replacement for the individual insurance market that existed prior to the Affordable Care Act. And somewhat lower than expected, the mandate to get insurance along with the tax penalties seems not to have been quite as effective as may have been envisioned. There are an additional 7 million enrollees that have coverage through the expansion of state Medicaid programs. That also is somewhat less than expected because when the Act was passed, obviously there was no way of knowing the Supreme Court would make the Medicaid expansion optional for states, and it turns out 19 states haven't adopted. And in particular, you might point at some very large states with high uninsured populations like Texas, which probably could contribute a couple million additional enrollees to Medicaid expansion by itself had they adopted. And then there's the third aspect, maybe the least controversial aspect of the entire bill, allowing young adults to stay on their parents' policy until age 26. And this has resulted in about a net increase of 2 million young adults with insurance coverage. In terms of where the gains were, they were broad-based. Any group you look at, demographically, age, race, sex, showed gains. But the largest gains proportionately were actually in the fairly young adult region, 26 to 34, had about a 9.8% decline in the uninsurance rate. That's a group that was relatively high in uninsurance to start with. And then Hispanic and non-Hispanic blacks also had above average declines in uninsurance rates. And here's just a trend from the Gallup surveys that are done quarterly, and you can kind of see when the main Act took effect, where you saw that big spike down from 18% was actually the highest point. It was a little over 17 in the last quarter before the Act's provisions took effect, and fell very dramatically to about 13.4% within the first few quarters, and then continued to decline gradually until roughly stabilizing at about 11%. Okay, so that takes care of 99.99% about what you're going to read about the ACA. Here's the rest of it. Second objective is to restructure the care process in this country to try to enhance the quality of care and the value of care that's being delivered. I'm going to highlight just a handful of initiatives related to the Act in this regard, and I'll talk a little bit about how effective they've been so far. One of the larger initiatives was the design of accountable care organizations. Now, a lot of these initiatives are focused at the Medicare population rather than the privately insured population that was the focus of the coverage expansions. But certainly these programs could have spillover effects onto the entire population. If the changes in care are adopted broadly, they're probably not going to be restricted to just Medicare patients. So the first is accountable care organizations. This is an arrangement where a group of providers would come together, hospitals, doctors, other types of institutional providers, and they would accept risk for a population of patients. If they meet their quality measures and come in at spending below target, they get to share in the savings. If spending is above target, they bear part of that excess. Second program is the Hospital Readmissions Reduction Program. One of the main problems with coordination of care that has been identified is transitions from one setting to another. Most importantly, the setting of the hospital back into the community. Inadequate care planning, inadequate follow-up has led to very high readmissions rates, so it was identified as an opportunity to both improve quality and reduce costs. So there's a program that has been implemented through the ACA to basically penalize hospitals that have excess rates of readmissions. Bundled payments, rather than paying for every little bit that's provided on a piecemeal basis, do a test, get a check. Have an office visit, get a check. Do a procedure, get a check. Standard fee-for-service medicine. Trying to move away from that by saying, well, there's a whole constellation of services around something like, say, a knee replacement. And we're just going to pay one flat rate for all the care that's delivered over a window of time around that knee replacement. And therefore creating incentives to coordinate care across those transitions and to deliver care efficiently. And the final one I'd like to highlight, although there are a number of others, Patient-Centered Outcomes Research Institute. This is an institute set up through the ACA to try to support research on what actually works in practice, not just works in a laboratory setting or experimental setting, but what type of care works best in actual practice. And it also has a unique feature of patients being engaged in that research process. It's not just the researchers. The patients have to be engaged even in the formulation of the research question and what outcomes matter most. So far, largely a mixed bag in this regard. Accountable care organizations, there have been some studies that have shown some beneficial effects on cost and quality. Others have not found much of an effect. The hospital readmissions program has probably been the most demonstrably successful to date. Readmissions rates have come down fairly substantially for some conditions. Bundled payments have also shown some success, and kind of too early to tell about the Patient-Centered Outcomes Research Institute. But basically we see a bunch of programs mainly targeting Medicare, and kind of too early to tell a lot of the results. A lot of these are just pilot programs in the Act, so they haven't yet had the power to transform the system as a whole. And a lot of them may just be prerequisites. ACOs may not be that successful yet, but they're encouraging the types of integration, relationships, information that might be needed as a prerequisite for success of future value-based care initiatives. Okay, objective number 3, so the second part of that 0.001%. Enhance public health programs and enhance prevention. And there's sort of two main ways that the Act does this. The first is all insurance plans, not just those sold under the ACA exchanges or Medicaid expansions, have to cover a set of evidence-based preventive care with no out-of-pocket cost to the patient. Even if you have a deductible that you haven't satisfied yet, the insurance plan has to cover these services. The second is something known as the Prevention and Public Health Fund. It was a fund that was intended to pay about $14.5 billion over a decade to the Center for Disease Control and Prevention. And it incorporates about 12% of their program funding now, and certainly is something that is at risk in terms of future changes. And some of that money has already been diverted by prior Congresses for other reasons. Focuses on areas, certainly state of Michigan, lead poisoning is something that is in the news a lot. Immunization, nutrition, obesity prevention, activity, tobacco control. So a lot of things that are sort of outside the main domain of the medical services that are covered by health insurance, but have an equal or as large or maybe even larger impact on health. It's been politically derided sometimes as a slush fund for jungle gyms, as if that's a bad thing. And to kind of put it in perspective, I've got a pie chart here with a really, really big section, a moderate section, and a tiny section. This is per capita spending in 2015. The huge section there is personal health services. So you got about $8,400 a person in this country. The blue essentially is how much does it cost to run the insurance system? the combination of what it takes administratively to run, say, Medicare and the VA and Medicaid, and on the private sector, what's called the net cost of insurance, which just kind of loosely you can think of as the cost of administration and profit to insurers and not the cost that they're spending to pay claims. And then the little tiny sliver that you can barely see is public health spending per capita. So essentially, comparing just the blue to that light yellow, we're spending 3 times as much just to run the public and private health insurance system, not to pay claims or pay for care, just to run the system, as we're spending per capita on public health services. So kind of puts in perspective some of the priorities that we've put in place in this country. Okay, so a lot of the publicity has obviously been about the rough patches that the insurance exchanges have hit. There's been a lot of insurer exit. In fact, in 2017, about 20% of health exchange enrollees literally had only one insurer to choose from. An additional 20% only had 2 insurers to choose from. There's obviously a lot of publicity over rising premiums in the exchanges. On a national average basis, premiums are about 20% higher in 2017 than they were in 2016. The variation across states is huge. Some states had flat premiums, really no increase at all. Other states had 100% or 80% increases. A national average is 20% increase. Again, still a pretty big sticker shock at the national average, but if you're in a state that's at 50 or 80 or 100%, even goes beyond that. Now, what doesn't get reported nearly as often is that the vast majority of people buying insurance on the exchanges don't actually face those increases. The subsidy they get to buy coverage goes up with the premium under the Affordable Care Act. So it's only about 1.5 million of the 12 million people who buy insurance on the exchanges that actually do have to pay this entire increase out of pocket. Those are the ones whose income is too high to qualify for subsidies. Now, for those people, these increases are very real. But it's a minor fraction of the total people that are involved. And then if we take a look at these big increases, despite them, we really almost matched our 2016 enrollment in 2017. In fact, like I mentioned earlier, we were running a little bit ahead of pace of 2016 until January, where we kind of lagged behind. So there's no evidence of sort of what's called a death spiral, where you get only the sick staying in the plan, therefore the rates go up next year, the few healthy remaining people drop out, the rates go up further, and eventually it spirals out of control. We don't have evidence of that yet. The CBO, Congressional Budget Office, has indicated they don't see evidence yet of a death spiral. An independent analysis by Standard & Poor's also confirms that. But there's great vulnerability of that for reasons that I'm sure some of the subsequent speakers are going to talk about in much more detail. Just simply the uncertainty. Will President Trump fight the lawsuit against the cost-sharing reduction subsidies? That's something that will be covered in much more detail. That uncertainty about whether he'll support that or fight it is going to play a large role in whether insurers want to stay in this market for 2018 and what premiums they're going to be comfortable charging. Okay, so what are the big picture questions that we have to ask? So these are questions that I think are true regardless of what particular proposal we're talking about. And since the particular proposal we might be talking about seems to change about it's probably changed since we started this talk. I haven't been on the internet in the last 15 minutes, so I don't know what's going on. I like to say the fundamental theorem of health policy is cost, quality, and access, pick any two. Now, what do people campaign on? They campaign on, I'm going to make your health care better and cheaper, and everybody's going to get it, as if there was no trade-off. In fact, there is a trade-off, and we all know that, even if our politicians don't tell us that. In particular, coverage that's cheap. I can make insurance really, really cheap. I can put really high deductibles, really high cost sharing so that it really doesn't cover much, and I can exclude a lot of things from benefits. No maternity coverage, no mental health benefits. I can give you a really cheap plan, that's easy. Now, those changes don't tend to be very popular among the public. One of the biggest complaints with the Obamacare plans is high out-of-pocket costs. So if I can make your plan cheaper by making your out-of-pocket costs even higher, it doesn't sound like a great solution to me. Second big question is, when we say we want to control the cost of healthcare, what are we actually talking about? And we're often talking about two different things. We could be talking about sort of a system-wide level. What is the cost of delivering healthcare to the US population? Regardless of who pays for it, the taxpayer, the insurer, or the patient out of pocket, the sum of all of those. How do we make that cheaper? Well, to make that cheaper, we have to either consume less care or cheaper care, so reduce the price of care. But a lot of people, when they're saying they want to control the cost of healthcare, they want to control the costs that they face themselves out of pocket. What's my personal cost? That's done if I can get a lower premium and more generous coverage. You can kind of see where these two definitions are often in conflict. If we give people really cheap, really generous coverage, they're going to have an incentive to use a lot of care and not worry so much about what its price is. So the things we might do to lower cost from one of these perspectives might increase cost from the other perspective. The third big question, who should pay for the sick? So Paul Ryan was quoted in the debate over the American Health Care Act saying, the fatal conceit of Obamacare is that people who are healthy pay for people who are sick. Okay. That obviously led to a lot of objections saying, well, wait a second, isn't that kind of the point? Okay. Intensity, it really is a big question. Do you want the healthy, the currently healthy, to pay too much for their premiums from a 2017 perspective so that the currently sick can pay, quote, too little from their 2017 perspective, but maybe with the idea that over the life cycle, these young healthy people, 20 or 30 years from now, are going to be the ones that are going to be the net beneficiaries of that? Or do we want the taxpayer to cover it? Or do we simply want the sick to cover their own bills? So it's a matter of social versus personal responsibility. What do we do if there's care that we believe you could benefit from clinically, maybe even save your life, but you can't afford it? Do you get it or not? These are the decisions we have to make, the big picture decisions, regardless of what particular detailed plan we're talking about. Finally, do you want an approach that is relatively heavy on government or relatively heavy on free market? And I put free market in quotes because we could really debate about how free a market in healthcare ever really could be. But if you think about the market approach, it really emphasizes personal choice, a choice of insurance plans, a choice of what they cover, a choice of what doctors and hospitals I get to use. That I'd have some level of personal responsibility. I've got to face some fairly high cost sharing to make me conscious to the costs of my decisions, particularly for non-catastrophic care. And we're not going to directly regulate prices, but we're going to rely on competition between insurers or between providers to keep prices down. So those are kind of some of the fundamental tenets if we move to a more market-based approach. So I think those are kind of the big picture questions that even if everything else I've said is out of date as of 15 minutes ago, these will not be out of date. Okay. All right, thank you.